Actually, it's my honor to step up in shoes of my teacher because Professor Sasank Joshi is going to take this lecture, but unfortunately he is not keeping well. That's why he was not able to come. So I am taking lecture on his behalf, and this is very important part because we are talking about gestational diabetes. We are talking about early gestational diabetes, and nowadays we are facing number of female who are already diabetic in their young life and now they are becoming pregnant, which is even complicating the thing, and that is mainly because of obesity and pre-diabetes or insulin resistance. So do we have treatment for that? Previously, even Dr. Pradeep has also elaborated one very good agent that is tirzepatide. Similarly, we have another agent that is semaglutide with us. How this obesity care is uh, going to help, going to change our scenario, that I am going to discuss. So there will be burden of obesity, need of pharmacotherapy, benefit of semaglutide 2.4 milligram, that is highest dose of semaglutide, and what are the safety profile. As obesity, it's a prevalent, complex, progressive, and more importantly, relapsing chronic disease. Why relapsing? Because once patient has reduced 10 kg, patient has stopped doing anything, patient will gain 12 kg. Then after 6 months, 1 year, another attempt to reduce weight, and that is relapsing again and again. And that is actually impairing health because of abnormally deposited fat or excessive fat. Both are very important. It is not always visceral fat. It is visceral plus excess of subcutaneous fat which is also causing this problem. And you can see the number. These are the number from world that 764 million adults are living with diabetes, 86 million adolescents are obesity, and 71 million children are obese. Children means less than 12 years of age, 71 million. And these are the number from India, 254 million people adult living with generalized obesity, but 351 million are living with abdominal obesity. Because we are thin fat India. We look thin, but we all have more fat in our abdomen, and that is causing more problem. And as far as overall multiple complications are concerned, we have grade 1, grade 2, grade 3, and grade 4 evidences associated with disease, and you can see grade 4 is with type 2 diabetes, CVD, that arrhythmia, hypertension, NAFLD, osteoarthritis, obstructive sleep apnea, few cancers like colonic cancer, breast cancer are more prevalent in obese people. And why? Because of multiple pathophysiology going on inside the body, which is increased adipokine synthesis, which lead to adipose tissue, macrophages and other inflammatory cell disinhibition, which leads to pro-inflammatory cytokine release. That also causes hyperinsulinemia, and later on beta cell dysfunction leads to type 2 diabetes. Pro-inflammatory cytokines along with increase in lipid production with more hydrolysis of triglyceride giving rise to more fatty acid, which leads to lipotoxicity and dyslipidemia. And that all are interrelated, which is causing MSLD, that is metabolic abnormality associated liver disease, and future cirrhosis also. Similarly, increase in activity of sympathetic nervous system and activity increase of renin, angiotensin, aldosterone system, RAS mechanism, which leads to hypertension as well as OSA as well as coronary artery disease and arrhythmia. And along with that, if there is increase in mechanical stress, more pressure to joint leads to osteoarthritis. And not last but least, that is GERD, which I think now again a very prevalent condition, gastroesophageal reflux and future Barrett's esophagus and esophageal carcinoma, which is awaiting because of that. BMI increases, life decreases. So these are the data where BMI is 22 to 25, 25 to 30, 30 to 35, and if patient is having BMI 40. Yes, there is another research that if BMI is less than 22, that is also reduces your lifespan. So being in a normal BMI is more important, and 5% of weight loss what you are having may have some benefit in diabetes, hypertension, dyslipidemia, but 11% weight loss can make wonder, and 15 or more than 15% of weight loss actually reverses fatty liver. It can make diabetes in remission. It can improve beta cell function, beta cell sensitivity, and it also improves obstructive sleep apnea and osteoarthritis. So more than 50% weight loss, if we can achieve in an obese individual, is going to benefit for all multiple parameters. These are the data with physical activity and medical nutrition therapy. They are good. They can do wonder. They can have 3 to 5% of weight loss, maybe sometimes up to 7% of weight loss if you combine behavioral modification along with that. If you go for bariatric surgery for morbid obese patient, then it will reduce 35 to around 25 to 35% of body weight loss. But what in between? Because 70% or 80% of our obese individual are actually falling in between. They are not going to benefit it only with diet, and they are also not needing bariatric surgery. So we have to have pharmacological therapy for that. We have few agents, we had few agents, but the previous lorcaserin, sibutramine, rimonabant, everywhere, I mean this all drug went out of market because of some complications. On the other side, we have orlistat, we have phentermine, topiramate combination, we have that bupropion, naltrexone combination with us to treat obesity, but they are not sufficient, strong enough to get more than 7% of body weight loss. So we need to bridge this gap whenever it is needed. So what are the data with this newer agent like semaglutide? These are the semaglutide 2.4 milligram phase 3 study, where it was studied in different way. You can see step 1 to 4, then step 5 and step 6 for East Asian, because Japan and a few other countries are having their regulation for their own data to get this agent passed. Everywhere it was compared to placebo arm. So one arm was control arm and other arm was a treatment arm who were taking semaglutide, and in semaglutide it was started from 0.25, 0.51, 1.7 and 2.4. So whatever the maximum tolerable dose was given, many of them were on 2.4, few of them were on 1.7, few of them were on 1. And we have multiple other studies separately for osteoarthritis, fatty, MASH. We have multiple study related to comparing to other agent, including liraglutide, which was the first GLP-1, I will say, which was approved for anti-obesity medicine as a Saxenda. The liraglutide higher dose was approved for that. And in all study, the weight loss, mean weight loss was around 18.2%, more than 20%. So 1 in 3 patients were losing more than 20% of body weight loss. And more importantly, if you continue this agent, 4 years, sustained weight loss is possible. The only problem here, which is lying here, the patient has to continue treatment for longer period of time. That is the only caveat right now. Step 1, step 2, step 4, step 5, step 8, step 2, step 6 and step 7. Step 2, 6 and 7 is important because these were done in diabetic group. By default, diabetic patient loses slightly lesser weight in comparison to non-diabetic. So you can see around 10 to 13% of the weight loss in type 2 diabetic patient, while in previous study, step 1, 3, 4, 5 and 8, almost 17-18% weight loss was found with 2.4 milligram of semaglutide. And for 5% of weight loss, which is ideal need for US FDA to approve any agent as anti-obesity medicine, which is 9 out of 10. So success rate is 90%. If you give this agent, 9 out of 10 people are going to lose 5%. 10% is lost in almost 75% of the patients. So if we Indian, we don't want 16%, we don't want 22%, we want only 10% of body weight loss. Still 75% of people are going to lose weight with this. And 1 in 3 is going to get more than 20% of weight loss. These are the weight loss across step study. Again, non-diabetic obese individual fared better in comparison to diabetic individual, but semaglutide 2.4 loses around 17 to 18% of body weight loss. Now, when it was compared to higher dose, semaglutide step-up study, where it was increased up to 7.2, which is the highest therapeutic level which we are obtaining for. In this particular study, weight loss was found up to 21%. So it was quite high. Now, along with weight loss, what are the other benefits semaglutide offers? Reduction in waist circumference, because I have shown you we are having more abdominal circumference, we are abdominally obese rather than overall obese people, 16.3 centimeter waist circumference reduction. HbA1c reduction 1.9% after insulin, strongest agent what we have. CRP, the inflammatory marker is reduced by 63%. Systolic BP, though it's not an anti-hypertensive medicine, but systolic BP reduces in double digit up to 10-11 millimeter of Hg, and 5 millimeter of Hg diastolic dysfunction, diastolic BP reduction, and triglyceride is also reduced by 22%. This is the data of semaglutide with cardiac risk or CVOT study. Semaglutide has suppressed other anti-obesity medicine in comparison to this, because this is the only agent which has shown 20% reduction in MACE, that is major adverse cardiac event, which includes myocardial infarction, non-fatal stroke, and non-fatal angina. So this suggests that these agents are not only beneficial for weight loss, but it actually improves your overall benefit as far as cardiovascular risk reduction is concerned and metabolic score is concerned. Now, if it is beneficial, do we have safety data for that? Yes, we have, because I have enumerated step 1 to step 10 trial, 11 trials, step up trial. 60,000 people across sustained pioneer and step clinical trial program has taken semaglutide by now. The safety profile is consistent with all other GLP-1 receptor agonist class, and it is, since its inception, it has found to be safe. The most common side effect is gastrointestinal side effect. So whenever you want to give this injection to your patient, always tell about gastrointestinal side effect. That is the only problem patient may face. Yes, there are few other issues that I would like to highlight. If patient is having thyroid malignancy, which is medullary carcinoma of thyroid in their family, don't give. If patient has acute pancreatitis, don't give, because there is occasional chance, but it is not causing so-called papillary carcinoma or follicular carcinoma of thyroid, which is actually the commonest one. And because here patients are losing weight and usually patients are having fatty liver, cholelithiasis can occur. This occurs with even bariatric surgery also. So that we have to see, and no increased CV risk is there, and no increased risk of malignant neoplasm as such. So you should not worry about this major side effect when you are giving this agent to your patient. So just to summarize, there is a growing burden of overweight and obesity in India. Pharmacotherapy like GLP-1 bridges the gap in existing management protocol. Semaglutide offers comprehensive cardiac and metabolic benefit. 2.4 milligram of semaglutide, that is at present available highest dose, because 7.2 is not available, offers weight loss up to 18%, and that is also 1 in 3 individual who can lose more than 20% of weight loss, and safety profile is well proven with this. So thank you for patient listening.